Good afternoon, everyone, and thank you, sir, for this wonderful opportunity of having me in your instruction course, and respected all my co-panelists and co-speakers. So I'll be talking on posterior uveitis. Can we solve the diagnostic dilemma? So I'll start with a few cases. This is case one, a 43-year-old male who presented with decreased vision in the left eye for 5 days, and vision was severely decreased to counting fingers. Now, as you can see in the left hand, there is a coin-shaped lesion right at the fovea, a whitish lesion, little smaller than the optic disc. And when we did a fluorescein angiography, we did not really find any clue except that there was some leak from the edges of the lesion, and we did not see any vitreous cells at this point of time. And the OCT showed us that the retina was involved full thickness in the fovea, and this showed some vitreous cells on the surface of the retina. Now, coming to the past history of patient, the patient was a known diabetic. He had a history of swine flu a month ago with bilateral pneumonitis and a couple of deranged blood investigations like low platelets, high sugar, and the throat swab was positive for H1N1. Now, considering his past history and considering the nature of the lesion, we made a differential diagnosis of retinitis, as the OCT also showed involvement of the retinal layers. So, this was an influenza retinitis, which is not a very common disease, but influenza retinopathy and influenza lesions in the eye are known to resolve with steroids. So, we started this patient on oral steroid. And to our surprise, at 5 days, his vision worsened, and you can see the lesion also worsened clinically. There's some hemorrhage, and the lesion is spreading horizontally. The OCT, if we compare it with what we saw at baseline, the lesion was almost vertically getting into the vitreous cavity. Now it's showing spread along the horizontal spread, not only along the retinal surface, but also below the neurosensory retina. So we immediately took up the patient for a diagnostic vitrectomy, and as we can see on the OCT, there were a lot of cells on the retinal surface here. So when we did the diagnostic vitrectomy, we took care of aspirating these lesions, these cells on the retinal surface. So we went very close to the fovea, and this aspirate was sent for KOH fungal smear, which revealed septate branching hyphae, and the pan-fungal PCR was also positive. The blast analysis revealed Candida albicans. So we started this patient on antifungal. So we realized that this was actually a patient of fungal endogenous endophthalmitis. And if we go back to the clinical stages of fungal endogenous endophthalmitis, we have chorioretinal changes without extension into the vitreous cavity. At this stage, it is known as only a chorioretinitis. And then the chorioretinal fungal mass penetrates through the iris into the vitreous cavity, which we saw in our patient. And then this is followed by an extensive vitreous infection. And then fourth stage is stage 3 along with associated retinal detachment. So when we look at what we saw initially, this was the first stage of second was fungal chororetinitis with vitreous invasion, and we halted this with a timely vitrectomy, removing the debris and treating the patient with oral antifungal therapy. So the lesion healed at 2 months, and we reported this as a fungal retinitis following influenza virus type A infection. This was an early presentation of an endogenous endophthalmitis. The second case is of a 67-year-old female who presented with decreased vision since a month, had redness and pain, and she had undergone cataract surgery 5 months back, but with poor post-op visual gain. She did not have any systemic comorbidities. Now, when we saw her right eye, you can see there are KPs, and the vision was just light perception. There is dense inflammation even at the back of the IOL. You can see the pressures were normal. And now, to our surprise, this is again the right eye. On the other, when we focus behind the lens, you can see the vessels behind the lens. So this is nothing but the detached retina, which is just abutting the intraocular lens. The left eye also had KPs. The vision was light perception. The pressures were normal. And we tried to take fundus photographs, and fortunately, we could capture something on the optos, wide field imaging. And you can see both eyes are showing exudative retinal detachment. Now, ultrasound showed retinal detachment as seen clinically. There was no mass lesion. The choroidal thickness was increased. Axial lengths were normal in both the eyes and same. Now, our differentials, because keeping in mind that this was a 67-year-old female, first episode of uveitis, First was masquerade, and then could it be a reg RD, but then bilateral, and we didn't see any break. We struggled hard to look for a break, but we couldn't. Was it a weak age disease or sympathetic ophthalmia or hypertensive retinopathy, uveal effusion syndrome? We had absolutely no idea what we were dealing with. So the patient, we examined her again. She was a thin-built old lady with just 40 kg of body weight. BP was normal, didn't have any lymphadenopathy. So all that we could do was, because we saw active inflammation in the anterior segment, we started her on steroids and atropine frequently, both the eyes. We got her labs done, we got her systemically evaluated in terms of blood reports, ultrasound, CT chest, MRI. We did not find anything that could contribute to our diagnosis. So taking her up for a surgery was the only option we thought we could, so that we could send her samples, was because her first differential was masquerade. So we took her up for a diagnostic vitrectomy, applied a buckle and tamponaded with SF6 because we made a retinotomy. We didn't find any break intra-op. The only thing that we found was the vitreous and the posterior hyaloid was extremely adherent and sticky. So since we made a retinotomy, we gave a tamponade with SF6. We sent both the vitreous samples and the subretinal fluid for cytology as well as PCR. Everything was negative, and this was post-op day 1. The vision is still light perception, IOP is normal, and we follow her up post op day 3. You can see the gas receding, and this is now where we start her on IVMP. After we got the reports of the PCR cytology, we didn't find anything, so the only option we had was, let's start her on steroids. Her vision is still light perception, and this is the after the 5 doses of 5-AMP. The right eye is still the same, light perception, vision, no, not much change. We switched her, this was the maximum we could give. We switched her to oral prednisolone gradually, and the operated eye, which is the left eye where we did the vitrectomy, vision slightly improved to hand motions from light perception at 3 weeks. No malignant cells, all PCRs negative, so we are still clueless here. But now, what we find once the retina is settled with vitrectomy and gas tamponade, you can see there is subretinal fibrosis nasally, and the kind of fundus now that appears with retina flattened is suggestive of, are we dealing with BKH? So this is where we had the suspicion as the gas started receding. Now, with 3 weeks, giving her continuously steroids, the retina started to go back in the right eye. Vision improving only to hand motions from light perception, and we can see the underlying choroidal reflex. So we think we are moving towards VKH. 3 weeks. And this is now where we are starting tapering the steroids. This is the baseline on top. And this is at 5 weeks now, where you can see the choroidal changes, the RPE pigmentary changes. The retina is still showing exudative RD, but much less. So comparing the two baselines, this is the right eye. Now, sorry, this is only the right eye. Baseline 3 weeks, 3 months, and 5 months. Now we have the classical findings of chronic VKH, and only after a long course of steroids. Similarly, the left eye, which underwent a vitrectomy, probably a diagnostic vitrectomy was not required, but when she was not responding to anything, and this gave us a clue when the retina started settling, subretinal fibrosis. So 5 months, she gets her counting fingers 2 meter vision. So the OCT shows subretinal fluid going back, and this is the final follow-up. She gets 660 vision, normal pressures, and we put her on immunosuppressants after that. So her retina is settled, and she is now good vision with ambulatory. She can do her work herself. Left eye. So this is how she is now at the last follow-up we saw this year in February. And this is the fundus photograph of the last visit. And this is how she began, and she presented to us with a severe diagnostic dilemma in both the eyes. Third case is a quick one. A 48-year-old male presenting with this kind of, this is the, he has poor vision in this eye, only hand motions. You can see there are a lot of cells in the anterior segment, and there's significant vitritis. You can see exudative retinal detachment, a lot of scars in the macula, and the IOP was not recordable in this eye. It was an extremely soft eye. The right eye on the bottom is normal with 6x vision. Now, the clinical course, if we go back to the history, this patient complains of poor vision in this eye since almost 20 years. He was treated elsewhere as TB neuroretinitis in the left eye. He had an on and off fair response to oral steroids. He would say, I get better when I take oral steroids. His treating ophthalmologist started ATT 3 months ago, and when the LFTs were severely deranged, he was switched to multi drug resistant TB treatment. His blood profile showed severely deranged LFT, IgG toxo-reactive, and TB quantiferon gold positive, and for which his treating ophthalmologist treated him with anti-TB therapy, and that too MDR TB treatment because he was not responding. So I'll take a minute. Sir.
Just, just give 30 seconds.
Yeah, I'll finish this case. So, as the patient had stopped oral steroids 15 days ago and he said he was doing well with steroids, we restarted oral steroids and we found that the vitritis started resolving. The exudative retinal detachment started settling inferiorly. And we could see these arrows show that there is a lesion in the upper nasal periphery. And here, this is where we suspected toxo. So, we started him on Septran DS and we asked him to ask his physician to start anti therapy. So, with follow ups, 3 weeks, 5 weeks, we could see also a break in this lesion, and the retina was still detached. And this is where we planned him for a vitrectomy. We took him up for surgery, did vitrectomy, tamponade, buckling, and this is how he responded. His vision came back. He's at least ambulatory. We couldn't get all the vision because his macula has lots of scarring. So this is how we started on the left, and this is how we could have him at the end of few months with vitrectomy. Thank you very much. And so these are some of the challenging cases of posterior uveitis that presented a diagnostic dilemma to us.
So